Africa Science Dialogue, closing the gap between science and society.
Now, as human populations increase and people go into new geographical areas, the distance between them and wildlife, actually even the distance between them and domestic animals, keeps shrinking. And amid all the benefits that are accrued out of the interactions between wildlife and human beings and domestic animals, there are some disadvantages to it. There's conflict, there's competition for resources, but there's also spread of zoonotic diseases and much more. As we stand right now, there is a lot of effects of climate change, not only on Africa, but the whole world, and a lot of land use changes due to pressure on land, deforestation, disruptions of habitats expose us to so many new challenges, which is why there is fronted what's called the One Health approach, and which is why today in studio I have an expert to talk about this all the way from Lusaka, Zambia, Dr. Raymond Hamonga. Dr. Raymond is the National One Health Coordinator at the Zambia National Public Health Institute. He's a One Health epidemiologist and health security specialist with over a decade of experience strengthening surveillance systems, zoonotic disease management, multi-sectoral coordination across human, animal, and environmental health sectors. He'll be telling us much more about this in the next half an hour or so. Dr. Raymond, how are you today?
I'm good, thanks, Peter. Thank you for having me today here.
Welcome to Nairobi.
I'm happy. Nairobi is like my favorite city in Africa.
Oh,
I love being here.
Thank you very much. Now, how is Zambia?
Zambia is okay. It's a little wet just like here, but
Okay.
it's not as cold as you guys are.
Oh, really?
Yeah.
There's so many questions to ask about One Health, and there's a lot of exciting things about you yourself, and especially the way you as a scientist have embraced communications. But let's first go to One Health that I have spoken about before. In February 2023, Zambia launched its National One Health Strategic Plan, which is a 2022 to 2026
Yes.
plan.
Yeah.
We're in 2026.
Yes.
So, what's the progress that you've seen in that period? And you can have the liberty of comparing it with before and after, or before and during that intervening period.
Yeah, sure. Thanks, Peter. 2023, if you dial back to 2023, this is a time when the One Health concept really, for our region, was a very new concept, okay? And one thing we were very sure, just like you said in your introduction, is that there is an interconnectedness of the environment, human beings, as well as the health of animals, both domestic animals as well as wild animals, even extending up to ecosystems. So for us, the One Health Strategic Plan was an opportunity to bring together various actors of this space. Remember, we are coming out of the COVID pandemic, and that really showed us how health in itself is not just a preserve of one sector alone, the Ministry of Health per se, but we all have all these actors who are sitting elsewhere. You may know that COVID-19 came from wild animals. Okay, it's a zoonotic disease, can be transmitted between humans and animals. So it brought to the fore the requirement for us to begin to look and safeguard this good we are calling public health in a unified way. And that's why we went into the strategic plan launch in 2023. So before then, one clear thing that I can say was not happening is that we never used to meet ordinarily in a meeting to discuss health matters with people who are nowhere around health to say. For instance, now we go in our meetings and we've got people from local government, municipalities, we've got army officers, Ministry of Defense, they sit in our meetings, we've got people, environmentalists, they sit in our meetings, veterinarians, medical doctors, we are all sitting in these meetings together. That is one of the key things that have driven our first strategic plan. And as you rightly said, we are at the intersection of now it has come to an end, and it has been a beautiful journey, but it has also showed us a number of deficiencies, changes in land usages, mining activities, climate and health. It's also becoming a big deal for us, and therefore as we go into the next phase, we envision that our next plan will even bring in more experts on board as we preserve the public health security of our country.
One of the things that was notable in Zambia especially was a response to an anthrax outbreak, if I'm not wrong, that
Yes.
is widely felt that because of this One Health approach was better handled than it would have been before. Are you able to tell us exactly how was that handled?
Absolutely. So for viewers and listeners who may not be familiar, anthrax is it's a disease that affects every warm-blooded animal. And anthrax itself, it's a bacteria which, when it comes in contact with air, it forms spores, more like the yeast spores. So it can stay in the soil for up to 100 years, just dormant, the bacteria. But once the conditions are ripe, things like flooding or drought, the spores can infect animals, and animals get anthrax. And secondly, when they get anthrax, when you kill an animal that has died of anthrax or eat it, you can also get anthrax as well. Now, it means, therefore, that anthrax operates at those three levels. It affects the environment because it can be dormant. Once a site is contaminated, actually, the vets will tell you, you don't have to take the animal elsewhere. You bury it on the spot. So it affects the environment in that way. It affects also animal health, and it also affects human health. So when we had our anthrax outbreak in Zambia, and coincidentally it happened in a region that had not reported anthrax for many, many years. None recorded in Zambia before, a place called Sinazongwe. And that came also from the death of a wildlife animal that died across in a neighboring country. So the way we responded is we were able to mobilize these three sectors in the One Health space at the fastest response. The environment guys were sorting out contamination of soils that have been contaminated. The animal health sector quickly moved in with vaccinations to vaccinate local heads of animals, while as the human health side of things, they were able to quickly go in and provide risk communication and community engagement messages to the communities about not being able to eat meat that has died of anthrax. So that coordination only happened because we were already talking. So these are colleagues who were operating at the local level, already members of One Health technical working groups. They didn't have to go through the bureaucratic processes of writing formal letters to various departments. Everybody was on the same page. And that was one truly good example of how One Health was very successful in a case study as that.
End of 2024, there was a drought that was across a few countries in the southern of Africa. I think it touched a little bit on Zambia. And governments were culling wild animals and feeding people. What for communities that are very, very close, who live on that we call it the interface.
Interface, yes.
That's it?
Yeah.
So for those communities, for them, we will assume that this is almost a daily practice.
Yeah.
How do they, and owing to the fact that you've said like the anthrax case is being reported from a place where such cases have not been reported before, how do these communities know exactly, or do they consult to know exactly what animals to probably eat
and not.
Yes.
So I know across Africa there are a lot of conservation initiatives because ultimately wildlife is a resource, just like any other natural resource. Countries have minerals, resources for us, and water, and therefore that's why there's a need to sustainably manage that resource for the benefit of the country and other communities. And in most cases, you find that communities do have mechanisms on how they relate with the wildlife protection systems in there. And bring it down to our country, we've tried to engage the community as part of One Health coordination mechanisms, in that the local veterinary officers have extension services provided the community. There are quick do's and don'ts that you can provide, like do not eat an animal that has died on its own. And because fortunately or unfortunately, one classic example of anthrax is animals just die suddenly. If you speak to a veterinarian, they tell you if you've got an animal, it has just died suddenly, what you suspect, one of the top things you suspect is anthrax, because that's how typically it kills off animals. So we provide that kind of information that you don't just eat an animal that died of itself, have at least a veterinarian certify that animal safe. Additionally, we also give messaging around properly cooked meat. you have to cook it well done, as they say in restaurants, right? Boil it thoroughly. You don't just undercook it. And as a rule of thumb, we just discourage the eating of game meat, especially that has died on its own, because there are so many pathogens that reside in animal populations. Some are yet to even be discovered. So you do not know what has killed an animal. So those are some of the safeguarding principles we provide to our communities living along the game management areas.
And are these communities usually heeding to this advice actively?
I think like everything that relates to community engagement is not, they don't always heed those advice, unfortunately. And that's because you need to look at the hierarchy of needs. Because if I don't have food and you tell me don't eat, even my own animal has died on itself, I tell you, what do you want me to do? Die with starvation or what? So it's a question of bringing the bigger picture to the fore and say, what is the bigger impact of you engaging in this kind of risky behavior? What does it predispose you towards if you're going to be undertaking or eating undercooked meat, for instance? So you have to bring the bigger picture to that. And also, like as I mentioned, wildlife is a resource. You need to provide tangible benefits for the communities around them. You gave a very good example. I think that was one of the southern countries where they culled wildlife to feed communities. Then people know that this is actually a resource that we can partake of, as opposed to just shutting them off and saying you can't touch wildlife even if you're starving out there. So if you don't do that, at least provide incentives, either government feeding programs to substitute home food security for such communities.
And of course, you are someone who is very well versed with science communication as well, more than just a scientist. And in the past, you've been the managing director of the Health Press in Zambia. And you collaborated with ZNPHI, which is right on your shirt there, Zambia National Public Health Institute and Ministry of Health, to revise, polish, and perfect articles in preparation for publication. Beyond that, I know that in other public fora, you engage people, you talk to people, you talk to communities, you talk to policymakers. Why does a scientist need to be a good communicator?
That's a very, very excellent question. Because you see, there is the concept of RCCE, risk communication and community engagement. But now, more specifically, when we talk about risk communication, what is risk communication? So, risk communication is normally defined as the science of telling people who are at risk of a hazard or a danger, that you are about to be consumed by this hazard. Therefore, to enable them prepare for that hazard. Okay? If I were to simplify it, it's like saying, there's a car coming behind you, please move out of the way. And that's what risk communication is all about. So I tell you, if you eat this meat, you're going to get sick. I'm communicating a risk to you for you to make an informed decision. Now, several times as scientists, we tend to fail our communities because the ultimate aim of being a scientist is to be a risk communicator. If I go into a bush, I collect a sample, I go into my laboratory, and I identify and isolate that this is a germ, it causes this disease. That is just one step of the thing. I've identified the hazard. The next step is I should now communicate this danger to the local communities. But many a time, as scientists, we rush to go and communicate to who? Our fellow scientists in journal publications. And that knowledge remains only among us scientists. And yet the intended purpose of every discovery we've ever had is for the general, and it's the general populace, the everyday person on the ground. And so a good scientist must therefore be able to translate findings to the ultimate beneficiaries, which are the citizens, the people on the street, to say, this is what we've discovered and this is what we can do about it. If it's not the people doing something about it, this is what the government can do about it. But several times we chase the prestige of high-impact journals, and then risk communication never operationalizes.
But Dr. Ray, seeing as I would assume that scientists, when doing this work, they recognize that the impact is intended for these people down there. And we know very well that
Absolutely.
those are not people who are coming to read the journals. What makes it difficult for scientists? What is that with the realization that, well, probably these people need to know exactly what I'm doing, that ends up stopping scientists from going ahead and communicating it?
Well, there are a number of factors that lead to that, but I feel sometimes it's also a failure in a number of how studies are designed and implemented. Remember that a lot of the studies we do actually involve participants drawn from the everyday communities. But several times, if you don't create that relationship with the community, and you just send enumerators in the field, they collect data, people run surveys with the only thing maybe you are getting out of that is consents, and people just say, oh, I consent to be interviewed. But without explaining why you are doing that, it becomes very hard for scientists now to go back to people whom they didn't explain why they were doing that before to communicate their findings. I've seen studies where scientists take the time to get that buy-in right from the onset and say, look, we are trying to find out the effect of obesity or the effect of hypertension or the prevalence of hypertension in this community because it's not documented. Then you tell people through, this is what hypertension is. You call it BP. We want to know what is that with you. From the onset, you hook in the community. Trust me, they'll be the ones who chase you and say, what did you find out was a problem with us, you know? But several times, if we are delinked with the end users of that data, it becomes very hard to communicate back once you have the findings. Yeah.
And we're going into a space where, because of course, climate change, rampant climate change and everything, and rapid population increase, the One Health approach has to be entrenched or communicated more. Like clearly, people you need to warm up to the idea. What are some of the biggest barriers to the approach, to the One Health approach?
Yeah. So one of the challenges we have, you hear this a lot, is people talk about silos, okay? I pity the new Gen Zs. They've never seen silos, but in the olden days, some of the towns, when you mill your maize, when you grow your maize and you take it to sell at the reserve agency, they pour it into these interconnected tubes, okay? That's why you'd fill one tube, you fill the next one, you fill the next one. So those tubes were actually called silos because it's one tube. So when they're distributing, you drain this tube, you get the maize, another tube, you drain the maize. That's where that term silo comes from. So like I said at the start, public health is multi-sectoral and there are many actors to it. But the problem is that people are working in those silos. That's been one of the biggest challenges we have. People, if I'm in animal health, I do not want anyone in human health to tell me how to do my job or to relate, and vice versa, including the environment. That is the challenge number one. Challenge number two, it comes down to understanding what One Health really seeks to do. So the One Health seeks to not to take away mandates of individuals. So we're not saying the vets must now listen to the medical doctors, or the medical doctors are listening to the veterinarians, or the vets are listening to environment. No, we are saying within your mandate, what you are doing must also speak to what others are doing. It should be a linkage.
Yeah.
A good example is rabies in our dogs. It's very important for medical doctors to know how many people are being bitten by dogs. Even the vets need to know how many people actually are getting bitten by dogs. Because when someone is bitten by a dog, there's a risk that they could get rabies. But the vet is the one who's at the better position to know whether this person should be given anti-rabies or not, based on examining the dog that bit that person. Why that is important is because if there's no that linkage, if the vet is not recommending to the doctor, it means the doctor, to be safe, will just prescribe anti-rabies for anyone bitten by a dog. And that is not an equitable use of resources. What is more realistic is to say, oh, you've been bitten, Mr. Vet, what do you think is the case? Is this dog a rabid dog, or is a non-vaccinated dog which just bit a person because dogs must bite people? That's why they're dogs, and that's their job. So somebody advises, says, no, this is just a normal case of a dog biting a person. Please don't prescribe anti-rabies, which is very expensive. Then we free up that resource for another person who may actually need it. It becomes efficiency. So silos, as well as number two, people not understanding the mandates that One Health is just enhancing coordination, not taking away your respective mandate as a sector. That seems to be one of the barriers. Yeah.
I actually love the second barrier that because with the example you gave,
Yeah.
I think that opens it up because it's quite practical about it.
Yeah.
For example, it also helps in social economy, whereby when you free the resources because
Yeah.
the vet advises you don't have to administer this and that to the doctor.
Yeah.
Of course, it's of benefit to more
Yes.
than just the people involved
Absolutely.
in that case. Now, in Kenya right now, as we speak, there are over 2.6 million people exposed to drought. And the northern areas of Kenya are very, very dry usually, and most of the communities there are pastoralist communities.
Okay.
So definitely when that comes, of course, there are so many domestic animals livestock that will die, others will be sold at throwaway prices too. What are some of the One Health risks that we might stand out of this whole thing that communities might not be aware of?
Yeah. So, foremost, obviously, a drought is one of the climate shocks we are experiencing, and I think it's becoming increasingly common to get not just droughts but extreme weather events. Some areas that have never had rains sometimes they experience extreme flash flooding. There's flooding all of a sudden. Others are experiencing extreme drought, like you said. Others sometimes it's temperature. So there are a number of shocks that are being associated with this climate change. Others will call it climate variability because it's a shorter period, and I think it's just unnecessary jargon. But nonetheless, in the case of a drought, one thing that is very critical from public health and One Health is the continuity of essential health services. Because in those communities, what extreme weather events do is they tend to disrupt those ones. And once these services or essential health services are disrupted, you see the rise in diseases. So let me give you a few examples. Let me start with flooding. Normally when you get flooding, roads get cut off. But remember that during that period, there are our mothers, expectant mothers, who need to be going for antenatal clinics. Sometimes power gets cut off as well, and that also affects the delivery and even the preservation of essential medicines in various health facilities as well. Then you come to issues of drought. Drought, one of the key things that tend to spiral out during drought is the proliferation in diarrheal diseases, because at times, one, we find that the water sources are reduced in number. The water quality and the safety of the water equally becomes compromised because now you get a dilution and concentration of pathogens in the water that you're drinking. Number three, you also get diseases affecting animals themselves. I gave an example in areas that have anthrax. During a drought, animals graze very close to the ground, and therefore they're able to sniff in anthrax spores much easily, and they become susceptible to that. Another thing that comes up if an area is close to wildlife is human-animal conflict, because wild animals and domestic animals, including people, tend to go to these watering holes that are still got water in them. So you see a rise in whether it's elephants coming into crops or in areas where people stay, or even predators. So you get that conflict again now between the wildlife and domestic and human animals, and that can also spiral up. So you've got diseases in human beings you need to look out for, especially diarrheal diseases tend to be rampant. We also need to ensure that there's continuity of those essential health services, because when during a drought, normally it's also hot, and therefore even the access to medical services tends to decline. So the people who are expectant, they're most likely not going to travel through the sun to go to a health facility. It means you need to bring extension services closer to the communities themselves. And then, like I said as well, if there's wildlife in the vicinity, you need to look out for the human-wildlife conflict and see how you can manage those equitably and in a safe way. Yeah.
I'm thinking specifically in sub-Saharan Africa that resources are usually very, very scarce in most of the places. I mean, in terms of you've worked with government, you probably
Yeah.
can tell us better what are these or is One Health, and especially because some places like I'm telling you in northern Kenya,
Yeah.
you should these things recur. It's a recurring thing once every so often. Are governments usually keen on investing, or how better to put that question is how best can our governments make sure that some of these areas that are very susceptible to these extreme weather conditions and where outbreaks of some of these diseases come up are well addressed? I don't know.
I hear you, and I think I hear your question. So, one thing that most governments would do is they will allocate resources. I think there are very few governments that have got challenges in allocating resources. But the issue, and where One Health comes to help in, is how do we allocate those resources? I'll give you a practical example that we've had before in Zambia. I've witnessed cases where you have a health facility which is stocking human anti-rabies vaccine, and that is it's quite very pricey. It's not a cheap commodity to stock. So we've had cases where a health facility will stock human rabies vaccine in case you're bitten by rabies, and the cost for as an example, let's say it's got stock worth maybe $1,000, okay, and the cost of vaccinating one dog is way just under $10, just one dog, okay? But you find that the cost to supply vaccines for dogs, there's poor funding towards that, but we are saying, to protect humans, let us have vaccine for human beings, which is more expensive. But if you were to take away that same resource from the human side of things and take it to dogs, science tells us that if you vaccinate 70% of the population of dogs in any community, doesn't matter where, just vaccinate 70%. If you got 10 dogs in your community, vaccinate 7 of them every year, once a year, annually. You never get rabies in that community.
Okay.
That is pure science. So it's way cheaper. So government stands to allocate resources, but it comes down now to ask the technocrats, the scientists, to guide them, to bring this place and say, look, we have got this movement. We are now working in coordination as One Health. Therefore, we need to share our resources allocation in a more meaningful way. Instead of you funding health alone, animal health alone, environment alone, we want to come up with joint work plans and see solutions that are specific to communities. Just like you said, if an area is prone to an extreme weather event such as drought, the funding for that area should not be the same as the area that has got no drought because their problems are unique. So it could be that maybe what they need more in that area is investment in water and sanitation, hygiene, infrastructure. They may need you to drill boreholes for them so that there's provision of clean water, as opposed to supplying medicine to treat diarrheas in that area. Maybe you need to supply resources to drill clean and safe water for those communities. And that is where One Health interfaces to bring these various actors, recognizing that the health of humans, animals, both domestic and wildlife, and the environment is interconnected, and therefore interventions must be equally interconnected as well.
One Health everywhere. And of course,
Yes.
that was the best example you've given of breaking down silos. A very generic question here. What makes a scientist a good scientist?
What makes a good scientist a good
What makes
scientist?
a good scientist?
Well, first of all, we'll say, who is a scientist? I think for me, a scientist is anybody who's breaking down any system into actionable and understandable complexes for the day-to-day person. Then you're a scientist, and that's why if a system that you are breaking down for us is soil, you're going to be a soil scientist. If it's animals and the behavior, you're going to be an animal behavioral scientist. So therefore, I always bring scientists. A good scientist, one, is the one who's a good communicator. It comes down to communication. Because ultimately, whatever it is that you're going to do, you need to communicate that to people. And unfortunately, scientists are one of the worst communicators. And I think it goes around most technical people. I don't know, I tend to pay attention and listen to the news. And if it's the medical doctors, they'll tell you, oh, we have so many cases of diarrhea admitted at the hospital. That is language for you as doctors. Because nobody goes and says, I'm going to see my case at the hospital. You say, I'm going to see my patient at the hospital. It's the small things like that where we tend to lose it as scientists. Or even if it's the police, they'll call the suspect or, use these terms. But at the end of the day, when you're a technocrat, your job is just to communicate what you are doing in a very easy way to the audience, which is the community ultimately, because that is who we serve. So I feel a good scientist is one that communicates very, very effectively with the audiences and the community.
Because that's how much communication can do to a scientist.
Absolutely.
And now on communication, and we are coming to an end of this. There's a lot of misinformation and disinformation, and especially in One Health, you're speaking to communities, most of who need this information very urgently, but probably don't have the technical knowledge. You have to be there breaking it down for them. But then there is, of course, the proliferation of social media and everything.
True.
Of course, they will get the quickest information from TikTok and elsewhere. It might not be correct. It might be anti-science, pseudoscience.
Yeah.
How do you manage to go ahead of misinformation and disinformation in One Health?
Yeah, that's I literally, I think people have gone as far as calling it a war on science, right? Because of the infodemic, or there's an outbreak of misinformation right now in the world we live in, and that became even more prominent during the pandemic, during COVID-19. There were so many theories, and people love conspiracies and theories. I don't know why. People would rather listen to something more exciting out of a sci-fi movie. So one of the principles of going ahead of that, I think, is timeliness of communication. And that's where I think many times we fail our people as government and scientists, because sometimes the information takes too long. There are so many clearing processes to get a statement out. But principles of good communication entail that communication must be done very timely. Like I mentioned earlier on, risk communication, you are telling somebody, there's a car coming behind you. What do you want to do about it? Do you want to step out of the way? Do you want to turn around and ask for a lift? So that somebody can make an informed decision very timely. But when there's no feedback, even when people are seeing there's a train coming and they're on the rail tracks, but you're quite a scientist, they're seeing this outbreak is coming, you're not coming in to tell them what to do, how they can prepare, they look for alternatives, because unfortunately, information cannot exist as a vacuum. People always find something to put in there. When there's no information, they'll fill it up with non-credible information. And therefore, as scientists, it is our duty to communicate very, very timely. And it sounds simple, but normally that's where the game changer is. If we are always reacting to the rumors and dispelling rumors, it's a signal that we are failing in communicating timely. Because even rumors need time to spread. But if you have something that's already there, authoritatively, ahead of the rumor, if you do it 2-3 times, trust me, people always say, we've heard this rumor, but let's wait and see what the ministry will say about this. And that all comes to timeliness of communication of our findings.
Yeah, it's a real infodemic.
Yeah.
Now, Dr. Raymond, whose professional focus is on translating complex, as you can hear, technical science into actionable policy and operational systems that improve public health resilience. Thank you very much, Doctor, for joining us today on this and breaking it down so well. I couldn't have asked for more. So here we say, I will say asante sana, which means thank you very much.
Okay.
And your response will be karibu, which would be you. You're welcome.
Yes, you're welcome.
So asante sana.
Karibu, Peter.
Thank you. That
Karibu to our
was.
listeners as well.
Yeah. Did you have any parting shot that you wanted to tell them? I thought you told them what a scientist is, maybe. Yeah.
No. I mean, thank you, dear listeners, and I think it's a great opportunity for us to have had this conversation, Peter. And scientists are meant and are there to save us, to communicate the risks that we face, and trust your scientists, and as well as to our fellow scientists out there. Let us communicate our findings in a timely way to communities. Thanks a lot.
I have no more to add or subtract. The good book warns against adding or subtracting to these words. He is the expert in this, and he, as you can hear, has done it for a long, long time. He knows exactly how it's done. Dr. Raymond Hamonga from the Zambia National Public Health Institute with us today in studio. This is the Africa Science Dialogue. Until next time, I'm Peter Theory. Thank you.
Africa Science Dialogue, closing the gap between science and society.